If you thought it was difficult getting a family doctor right now, think about what it might be in the future. Hi, I'm Brian Lilley, political columnist for the Toronto Sun. A new report out by the Canadian Institutes for Health Information, CIHI, has announced that the rate of growth for family doctors is slowing from 3% over the past few years to just 1% now. Well, our population is growing at a much higher rate, even with the Trudeau government's announcement that they're going to at least try to reduce the number of immigrants, the number of people coming in on temporary work visas or international students. Our population is growing at far bigger than 1%, and family doctors are growing at exactly that rate. How is this going to impact us? Joining me to talk about this is a general practitioner, a family doctor, my good friend, Dr. Barry Dworkin. Dr. Barry, hello,
Hey,
how are you?
I'm fine, Ryan. How are you doing?
I'm well. Look, you run a family medical practice in Ottawa. You've got how many thousands of patients on your roster, and always demand for more. Tell me the impact of this type of slowing in growth. We'll get into why it might be happening in a moment, but what's the impact for patients searching out to find
Uh,
people like you with
Well,
this slowing in growth?
the impact has been borne out just over this past year. We had one physician who moved back to the United Kingdom because she couldn't get her permanent residence in Canada. So there were,
Then this was a doctor in your practice that
yeah,
you
yeah,
talked to me about.
yeah, and
So,
I think you covered that too.
yeah,
So
give me that quick story.
yeah, so she wanted to practice family medicine in Canada. She applied to the federal government for permanent residence so that there'd be some security because if she didn't get permanent residence, she would lose the ability to stay in Canada. And if she stayed in Canada for too long, she would lose her UK license. So then she'd be a physician without a license anywhere. So she needed the security of having permanent residence. So the Canadian government, in all its wisdom, said, well, because you're over 45 and because you're not married, believe it or not, you don't have enough points to stay in Canada, and they didn't approve her permanent residence. So she went back to the UK to practice. So 1,200 patients that she had in her roster were gone because we can't absorb 1,200 patients. So that's 1,200 patients off from the practice. We have a physician who's now retiring this coming April, and that's another 1,400 patients who will lose a family doctor. We can't absorb those patients. We have 12 physicians now, 13 physicians. You
And
can't,
so within your practice,
yeah,
you run a family medical practice in kind of Southwest Ottawa.
yeah,
You've got 12 or 13 physicians.
yeah. 12, we have now 13, soon to be 12. We
Okay, and
had,
how many patients total?
so now we have, on average, people have about 12 to 1,600 patients per physician. So if you have
Okay.
13 physicians, you're close to, 17, 18,000 patients. It was 20,000 when Dr. Bilcher was here. So that's a lot of patients.
And so you're losing people to retirement. You're losing people because the government's being morons. And think of all the people they've approved over the past few years, and they reject a physician because she's over 45
Yeah.
and an unmarried woman. Oh goodness! I
Yeah,
mean,
no, I know.
how could
No.
we allow that? Um, you know,
It's horrible.
we shouldn't be laughing, but what else are you going to do?
Yeah.
So the slowing growth of people entering family medicine, this is across the country, but my understanding is in Ontario it's especially acute. But so yeah. If you're losing physicians at a rate of probably 2 to 3% a year, 1% growth is not going to deal with that.
No, it's not. And people are going to ask, well, why aren't there more family doctors? Well, there are some, if we get to the actual main reasons, in order to practice your profession, you want to have all the supports necessary so you can do a good job. And if you don't have those supports available, it becomes increasingly difficult and more frustrating to do that. If you then interject bureaucracy into it that oversees everything that you do, and that you have but 20, sometimes 20% of your time, 25% of your time occupied by filling out forms and other bureaucratic niceties, it becomes less palatable. When you have a situation where you have unending or unceasing demand for services, and you're not able to keep up with the number of people that are trying to see you, that also creates frustration not only for the patients but the physicians, because they want to see those patients. They just don't have the time to do that. So ultimately, you're dealing with support issues, right? You want to make the work environment as attractive as possible. Just like any business that's recruiting people, you want that business to have a good reputation. You want that business to be able to provide you with the services so that you can do your job. And when that is lacking, that becomes an issue. Why is it lacking? Well, there's a great analogy that I like to use, and I talk to my patients about this a lot. Say you have a person that runs a pizzeria and they make pizzas and they charge people whatever the cost is to make those pizzas. And then the government decides, hey, free pizza for everybody. We're going to give you a pizza card. And so people go with their pizza cards and they go, wow, free pizza. So now you have lineups to see the pizzas.
Everyone loves pizza.
Yeah, of course. And the card that you have is only paying the pizza owner, the restaurateur, 50% of what the true cost of the pizza costs to make. So what do you think happens? I'm going to ask you, Brian, what do you think happens if your card only pays half of what the actual cost is of the product that you're going to get?
I'm going to get a smaller pizza.
Yeah, you're going to get a smaller pizza. You're going to have cuts in staff because it's going to cost too much to have the ability to make the pizzas. Pizza production is going to slow down because you don't have enough people to do that. People are going to be lining up more. People are going to be getting upset because they can't get their pizzas on time. And the owner is going to say, well, I can't even work the same number of hours anymore because I've left staff. So I have to cut my hours. Otherwise, I'm going to completely burn out. So that's our healthcare system in a nutshell.
I mean, has ever been thus, though? I can't remember a time when you couldn't say the healthcare system was in crisis in this province, in this country. So how do we get out of this? You mentioned paperwork, and I was speaking with Ontario Liberal leader Bonnie Crombie, who's trying to come up with a new healthcare plan. And this is no passing judgment on Miss Crombie. I've just stopped listening to politicians when they talk about how they're going to reform healthcare, because it has been going over. They've been making promises for decades, and I don't notice a big change. We'll talk about some of the changes coming in a little bit, but she said there's way too much time spent on paperwork for doctors, and we need to fix that. There's always going to be a certain amount of paperwork, Barry. And I say this as someone who is horrible at administrative tasks, who does not, fill out my expenses. Oh, I'll get to it. That's money owed to me. It's still a pain for me to do. Filling out any paperwork is a pain. You've always got to have a certain amount of that. What is happening now in the health system that is causing you undue paperwork? Because you've got a chart for the patients, you've got to keep records. Well, I gave them this, or I treated them for that. Sure. Where's the balance?
So it's predominantly, when we talk about paperwork now, it's also electronic paperwork. So you have
well, when I see you come in with an iPad and just punch everything.
Yeah. So we have electronic records. So everything comes in through the electronic record for the most part, even insurance forms that come in as PDF files. So it's the insurance forms for medications, it's the insurance forms for disability, it's the insurance forms for disability tax credit, it's for return to work, it's for psychiatric assessments. It goes on and on and on. And it's insurance companies that literally beat you to death with one end-ending form after another. It's not the patient's fault. I'm not blaming patients at all for this. It's the insurance companies that think willy-nilly they can keep sending you forms ad infinitum and think that you have all the time in the world to fill this out. And you fill them out, and then they send you additional questionnaires. And remember,
it's not even government paperwork necessarily.
It's not necessarily government paperwork. There are parts of the job that you have to do, right? Every day in my inbox, there are 40 or 50 lab results to review, and there's consult notes to review and prescription renewals to do. That's part of the job. I understand that. And that takes time. And we can get into some of the ways to circumvent some of that too, to reduce that. And so that can take several hours a day just going through the chart results. So when patients say that they can't see their physician, it's not that the physician is not there. It's that a lot of time is being taken to actually process the information because then you're managing patients on the basis of their test results.
Well,
So
you
there's that.
send me for a test, let's say, you
Yeah,
need to review the results to know, okay, well, Brian has this.
yeah. And then I email you to let you know what the result is and what the management thing is done, or do we have to consult, do a consult to a specialist for something? So all of that is part and parcel. And look, that's the job. I'm not complaining about that at all. In fact, I enjoy when I can fix something and help someone out, right? So that's the benefit of doing that. But it's the sheer volume that's the issue, right? It's the feeling like you're on a hamster wheel going nowhere at times. You're just spinning and spinning and spinning. But there are solutions to this, right? I mean, again, we talked at the beginning about making a practice attractive for family doctors. A lot of medical students are not choosing to go into residencies or training programs for family medicine because, frankly, they're coming out with huge debts and they're looking at what areas of interest do I have, because they will have varied interests. They can be interested in family medicine and they can be interested in surgery or internal medicine or pediatrics or a whole host of different specialties. And part of the decision-making process is not only what am I interested in, but it's what's going to be able to provide me with the means to pay off my loans. And so you will have people, for example, that do go into family medicine, but then don't practice comprehensive care medicine or community medicine. Why? Because they can do sports medicine, they can work as a hospitalist. They decide to work in a hospital where they see patients in the hospital. They're going to make 3 to 4 times as much as a family doctor working in a community practice. Why? Because they have no overhead to pay. There's no overhead.
I just heard of one doctor who left family medicine and just goes from locum to locum. That's
Yeah,
filling in for doctors who are away at hospitals.
yeah,
And they make more money being the fill-in person while
right.
your local doctor at the hospital is away on vacation.
Right. And we're not talking about more money on the basis of, oh, we've got to boost up physicians' salaries. You can make a very good living as a family doctor. That's not the issue. It's the overhead. That's the issue. It's the cost. It's that pizza. It's the cost of making that pizza and then providing a good work environment. So how do you make a good work environment? Well, you make a good work environment by having ancillary staff, uh, professional staff to help out. So, for example, we have 6 nurses, 5 or 6 nurses, nurse assistants in our practice. So they do a lot of patient care too. They'll do treatments for using liquid nitrogen to treat warts and pap tests and follow-ups and medication follow-ups and blood pressure follow-ups and injections and vaccinations. So a lot of stuff gets transferred to that so that it's a good use of their time to do that, right? But at the same time, you still have all the other things that the physician is doing, the lab results and the ability to see patients that need to see them. So you have a lot of patients come in for minor things. To the patient, it's a major thing, but it can be triaged. And if it's a minor thing, you have a nurse practitioner that can see them. You have a physician assistant that can see them. The
That all
problem,
costs money
exactly.
to you.
Correct, because there's no funding for that. And if there is funding, you're filling out 20 to 25 pages of a form saying why you need this person in your practice, and then have to write ongoing forms to evaluate how it's going in the practice. I don't have time to do that. I'm running a practice. I don't have time to beg and plead for grants. That doesn't help in the long term.
Let me ask you about this before we run out of time here.
Sure.
Here in Ontario, the Ford government has established 2 new medical schools, which is great, but it's not a short-term fix. That's
Yeah.
I would guess medium to long-term fix, because by the time people finally graduate from these schools that aren't quite open yet, we're talking a decade before we're going to be adding. So that's a good long-term fix. And when I've been asking around, well, what's a short-term fix? People have said to me things like, well, there's not enough residencies and people want to practice but can't get a residency. Is that an ongoing issue?
I would say for family medicine, no. And the reason is every year there is what's known as the Canadian Residency Matching Service, or CARMS. So that is a central repository where medical students will send in their CVs, send in their evaluations, their medical evaluations, and their choice of residency training program, be it family medicine, surgery, etc. And they rank it, saying, I want to go to family medicine at this place first, I want to do this second, third, and it's ranked. They go for their interviews. The people that interview them send all their results back to CARMS. And then CARMS looks at it and says, yeah, you've placed into this. Well, the number of people that applied for family medicine, there were 270 open residency slots last year for family medicine residency, meaning no one wanted
across
to
Canada
do it.
or Ontario?
Across
Okay.
Canada. No one wanted to do that. And that's a number that keeps increasing every year. It used to be 95% of, and this is from CARMS data, 95% of all residency positions in family medicine were filled on the first pass by people who want to do family medicine in the past. Now it's down to 85% and continues to decrease. So that is an issue. So it doesn't matter how many residency positions you have. If there's no interest, if the demand is low, you've got a big supply and it becomes cheap. No one wants to do it. So that's the problem. How do you solve this though? Well, you solve it again. Let me ask you a question. When you go to get your medication filled, when you go to a physiotherapist, when you see your dentist, a bill is given to you, right?
Yep.
And your insurance company will cover 80 or 90% of that, and then you co-pay the rest of it. I think that's so that happens in every specific medical service being provided. You go to the hospital to see your specialist, you're paying $20 for parking to see your specialist, right? It goes into general revenues in the hospital. So what is it that's missing here? Well, in Ontario, the Ontario Health Insurance Plan, that's what it is, it's an insurance plan, is only paying a fraction of what the true cost of the service is. If people have no problem accepting that when they go to buy their medications, see their chiropractor, see their physiotherapist, massage therapist, and that the insurance company will say, we're paying 80 or 90% and you pay 10%. Why? Because that extra amount that you're paying is covering the true cost. We calculated that for our practice, we could get 2 nurse practitioners, a physician assistant, increase the artificial intelligence aspects of our EMR to record interviews and make chart notes for $10 per patient per visit when they come in. That's what it would cost to generate enough money to be able to provide that. And that would then create the environment for physicians to go, hey, you're providing all these services. We have the ability now to provide you a better work environment, and you attract people because of that. And it's $10. I'm not kidding. It is $10 to be able to do that when someone comes in.
Barry, I would, Dr. Dworkin, Barry, I would, known you long enough.
Yeah.
I would gladly pay that. But here's the problem. You've got a majority of the Canadian public who thinks that you are not a private practitioner, that you are a government employee, and that they are entitled to free health care because they don't make a connection between the high taxes that we pay and what it costs.
Yes.
And so any government that attempted to do that would be voted out of office at the next election. Maybe an NDP government, if we had one, could pull that off.
Right.
But I don't see us getting an NDP government anytime soon. And the federal government would try and disallow it. So while it makes sense, it is in this day and age a political dead letter.
It can be if it's presented that way, except that again, the facility fee is not something that goes to the physician, right? So right off the bat, that $10, and by the way, you can easily incorporate into a health card somebody that's under a certain income that can't afford that.
Absolutely.
So the government would cover that cost. I'm not saying everybody has to pay; it has to be within the means of doing that, but it goes to the facility. The facility is the business. The business hires the staff. That money goes directly to provide extra services. The physician's income is a separate issue with OHIP altogether. That has nothing to do with the facility within which they're working. Their overhead goes to providing the facility with income as well. So it's a top up to the income so that the practice can provide those services. The issue also, Jane Philpotts, who's now Dr. Philpotts, who's now has some sort of committee to look at things, cited, I believe it was the Netherlands, as an excellent healthcare system. Except the Netherlands has exactly the system I just said.
The copay.
A copay, and people are, and she's touting how good the service is. Well, you can't do apples to oranges. If you're citing in Europe systems that work so much better because people have insurance, they're mandated to have insurance, and insurance companies are mandated to provide it because without any restriction. So if you have a health condition, doesn't matter, they still have to cover you. They can't cherry pick. And then the person can choose where they want to go to get their services. But family physicians in the Netherlands charge a fee. Finland has a fantastic family medicine system. They charge $40 when people go for a visit. I'm saying $10. And again, doesn't go into my pocket. This is the key thing for people to understand. It's a funding issue. Governments are continually saying they don't have enough to pay for the system. There's a lot of bloat. You have 10 times as many bureaucrats. Again, I think you looked that up, Brian, when I mentioned that to you. 10 times as many health bureaucrats per capita here than in Germany, which has twice as many people. So you have all this money that's going into areas where people are not seeing any patients, not providing any care, and that money gets sucked down the drain.
Well, I remember years ago, this tells you how long ago it was, Gilles Duceppe was still the leader of the Bloc Québécois. And he used to say, why do we have 10,000 bureaucrats at Health Canada and they don't run a single hospital?
Yeah.
I'm sure it's probably 15, 20,000 bureaucrats at Health Canada now. They take up a lot of money. In the provincial system, province after province, you can find the same thing, eating up costs.
Yeah.
So I get it. And I agree. We need to have an understanding. Unfortunately, it just seems like Canadians are stuck in this mentality of anything that isn't exactly what we have now is American style, even though it might be Finnish, it might be Dutch, it might be French, it might be German. All these systems that are much more similar to ours do these things. And we've just, St. Tommy Douglas promised us free healthcare decades ago, and we can't get past that. I think we should, and I think people should consider what you're saying and what Dr. Philpott's saying.
I think Tommy Douglas also said that people should be paying a certain amount when they go for visits too. So it wasn't completely free. So that was conveniently left out of the equation. I think there is a bit of a sea change in how people are thinking, because they see in Ontario, for example, 2 million people without a family doctor. In another 2 years, there'll be 4 million because there's a lot of retirements coming. And again, there's no replacements. And those physicians that are retiring have greater rosters. A lot of new physicians want more of a bit of a balance. They have a lot of young families. And I don't blame them. And so there's that issue where you're not necessarily going to get a one-for-one transfer of patients from one practice to another. But I think if people see that, again, not asking for the moon, we're trying to provide the services that our training has created, right? We want to do the best job we can. But if you're not able to do that, and again, I'm not being facetious or sarcastic about this. It is $10. That's all it is. Because we have 4,000 visits a month. That's $40,000 a month. That's $500,000 a year. That covers nurse practitioners, physician assistant, increasing our ability to our technological budget to be able to do more that way, makes it much more valuable for physicians to work in that environment, and make sure
it allows you to see more patients. So
yes,
right.
That's right. Yeah,
we'll put it to the audience and we'll ask them what they think. So Barry, thanks so much for your time. You're always informative, and it always spark a good conversation. Drop a comment down below, share this on social media, and don't forget to subscribe to our channel.